Let's continue the second part of the lecture. So in this part, we will cover on the changing oral corticosteroid regimens, and we will cover on the pharmacokinetic and mechanism of action of the glucocorticoid and mineralocorticoids, beside the potential side effect of the adrenocorticosteroid drugs and supplemental measure to overcome the side effects. So let's begin. So how to change the 20 mg TDS of hydrocortisone to oral prednisolone, which will not affecting the potency of the glucocorticoid drug in the body. So first of all, to change it, you must refer back to the equivalent glucocorticoid dose between the hydrocortisone and prednisone. Here you can see 5 mg of prednisone are equivalent to 20 mg of hydrocortisone. But not as easy as that. First of all, you need to calculate the daily dose of hydrocortisone. So the daily dose of hydrocortisone is 60 mg by 20 mg times 3. So to calculate the daily dose of the prednisones, you must compare the equivalent glucocorticoid dose and using the ratio method proportions. So the daily dose of the prednisone, which is 15 mg. Usually the 15 mg of the daily dose will be divided into single dose. Our practice here, the 2/3 of the daily dose will be given in the early morning, which is 10 mg, and another 1/3, which is 5 mg, will be given in the late afternoon. So based on the current available strength in the pharmacy or market, the prednisone is available in the strength of this. So you can choose any strength and easier for patient to take it. So for those who given their 10 mg prednisone tablet and another half tablet in the early afternoon or late afternoons. So for those who choose to give 5 mg tablet of prednisone, so you need to counsel them to take 2 tablets, which is equivalent to 10 mg in early morning, and another 1 tablet in the early afternoon or late afternoons. So let's continue on the pharmacokinetics of our corticosteroids. So mostly the exogenous corticosteroids are highly bound to the plasma protein, which is corticosteroid binding globulin, or to the albumins. So they will will be absorbed, and once it's reached to the liver, the inactive form of the drugs will convert to the active form, such as the cortisone drug will convert to the hydrocortisone, which is the mimic of the cortisone drugs, and for those who took the prednisone, will convert to the prednisolone. So the hydrocortisone and prednisolone is the active form of the glucocorticoids. And prednisone is preferred in pregnancy because it minimizes the zero effect on the fetus. Any prednisolone formed in the mother is biotransformed to the prednisone by placental enzyme. So that's one of the benefits for those who are pregnant. And cortisol can be metabolized and be excreted through urine. So the major metabolite excreted in the urine, which are 17 hydroxysteroids and 17 ketosteroids. Besides that, 20% cortisol is converted to cortisol by 11 beta HSD. HSD refers to 11 beta hydroxysterase dehydrogenase. Only 1% cortisol excrete unchanged through the biliary excretions. Let's continue the mechanism of action of glucocorticoid that exert anti-inflammatory activities. I want you guys to have a look at the picture here first. You can see the free cortisol will diffuse across the cell membrane to the cell and binds to the cytosolic glucocorticoid receptors that induce the receptor ligand complex to form the dimers. These dimers will actively translocated into the cell nucleus and bind to the glucocorticoid receptor element of target genes. This binding will cause transactivation and transrepressions. For the transactivations, this binding will synthesize the anti-inflammatory proteins such as anasin-1, secretory lipoprotease inhibitor or SLPI, inhibitor of nuclear factor Kb or IKB alpha, and else. This anti-inflammatory protein will inhibit the COX-2 and PLA2. The binding of these COX-2 and PLA2 will inhibit the inflammatory mediators such as arachidonic acid, prostaglandin, and leukotriene. So it will exert the anti-inflammatory activities. Besides the dimers bind to the GRE, it will cause the transrepressions, which will inhibit the production of inflammatory proteins such as cytokines, interleukin 1, interleukin 2, interleukin 6, and TNF alpha, beside the inflammatory enzyme and adhesion molecules. So this is the mechanism of action that how the glucocorticoid will cause the immunosuppressive effects. The glucocorticoids will prevent the monocytes from apoptosis, and also the glucocorticoid will promote the macrophage here to phagocytosis and motility, but it inhibit the adhesion, apoptosis, and oxidative burst. This glucocorticoid also will inhibit the production of pro-inflammatory mediators such as cytokine, chemokine, ROS, and RNS by macrophage and monocytes. Glucocorticoid also will inhibit the rolling, adhesion, and activation of neutrophil functions. And beside that, glucocorticoid also will act toward the dendritic cells by promoting their maturation, survival, migration, and motility. And the glucocorticoid will inhibit their ability to activate the T cells by suppressing the production of pro-inflammatory molecules. Besides the immunosuppressive effect, the glucocorticoid also has the anti-anaphylaxis effect, which will inhibit the histamine release by the basophil and mast cells. This is the mechanism of action for mineralocorticoids, which is aldosterone, that has the water and salt retentions. As you can see here, the mineralocorticoids or aldosterones will act on the kidney tubules and also as well as on the collecting ducts. The binding of the mineralocorticoid on the receptor will causing a reabsorption of sodium, bicarbonate, and water and lead to the decreased reabsorption of potassium and iron hydrogen, then loss in urine. So enhancement of sodium reabsorption also occur not only in the tubules, in the kidney tubules, but it also can occur in the GI mucosa, sweat, and salivary gland. So this condition will lead to increase in blood volume, blood pressure, also may cause the alkalosis and hypokalemia. This is the last part of our lecture here, which is side effect of corticosteroids and how to overcome it. You can see the picture here, the red color picture here is the side effect of the corticosteroids. So for those, especially women who take the long-term therapy of corticosteroid may face the osteonecrosis or osteoporosis of the bones. So usually we will suggest and recommend them to take calcium and vitamin D3 to overcome these issues. Besides that, this patient also may face myopathy of muscles, weight gain, and obesity. So, the calorie management and high protein diet are emphasized to these patients. The patient who take the long-term corticosteroids also may face the fluid retention and edema due to the mineralocorticoid effects. As I mentioned earlier, the mineralocorticoid effects will cause the salt and water retained in our blood. So, to prevent it, we will suggest them to take the potassium salt instead of the sodium salt. Another side effect of patients who take the corticosteroids, which is hyperglycemia. Hyperglycemia is the high glucose in our blood due to the glucocorticoid activity. So this hyperglycemia will impair the glucose metabolism, insulin resistance, and beta cell dysfunction. Be aware, for those who take the corticosteroid together with the NSAID will induce the gastric ulcer. So antacid may prevent it. It is a supplemental measure to overcome the side effect. So we will suggest the patient to have their diet rich in potassium and low in sodium salt. Besides, they need to do the caloric management to prevent any obesity and to take the calcium and vitamin D to prevent any osteoporosis. So that's all for today. If you have any questions, you can leave your comments on the forums down there. Thank you guys. Keep calm, stay safe, and Assalamualaikum.